Hello everyone, my name is Sydney Beaulieu and today I'll be presenting on the topic of trauma care approaches. This presentation is an opportunity for me to explore trauma-informed care a bit more deeply and share some key insights that can help us all provide more compassionate and effective support in our professional roles. The main reason why I chose this topic is because as a practicum student, I've seen firsthand how trauma impacts individuals in a variety of ways, emotionally, physically, and psychologically. Working in the field, I realize how essential it is to understand not just the effects of trauma, but also the best practices and approaches in supporting individuals who have experienced it. I really wanted to start off this presentation with an opening quote that states, "The body remembers what the mind forgets." Another quote that's quite similar to this that maybe you guys have seen or heard of is, "The body keeps the score." So this quote and these quotes together really speak to the core of trauma work. It highlights how trauma isn't just stored as a memory, sometimes it could be held in the body, even when the mind may not fully recall or understand what has happened. Understanding this concept is key to approaching care with sensitivity and awareness that we will talk about later in these slides. And it also reinforces the importance of trauma-informed practices that recognize the deep and sometimes hidden ways that trauma can affect an individual, and in our cases, our clients as practicum students. So within my presentation, we'll be covering the definition of trauma and its impact, the neurobiology of trauma, the trauma types, consequences, and prevalence, why trauma care is important, the foundations, evidence-based models, a phased approach to trauma care. I will be presenting a case, an application where you guys can apply the previous slides into the case. I also will be covering the applications in counseling, education, and in the community, our role as counselors and the challenges that we have and that we will face, a bit of ethics and cultural considerations, and then we'll jump into the conclusion and discussion. So I'm just going to share a short video that gives a quick overview on what trauma is. So this is a simple but powerful explanation that helps break down how trauma can affect a person, not just mentally, physically, and emotionally too. I feel this is important to include because understanding the basics of trauma is the first step in being able to respond to trauma with care and awareness as counselors. So let's take a moment to watch this video, and I will be including this video in a link in the description so you guys can listen to this 3-minute video before we jump right into our presentation. Trauma is essentially an emotional response to an event or a series of events that a person experiences as harmful or life-threatening. It's also important to remember that trauma isn't just about what happens, it's about how a person experiences and processes through these events. When someone experiences trauma, it can overwhelm their ability to cope, affecting not only their emotions, but also their body and their relationships. Trauma can have long-lasting effects that go much more further than their memories or their feelings. A key point is that trauma is deeply connected to how the nervous system responds to these events. This means that two people might go through the same experience but react very differently because their bodies process the trauma differently. So it's very important that trauma work is very individualistic, and also there is no one-size-fits-all approach. Trauma can come from many sources, things like accidents, abuse, violence, natural disasters, medical emergencies, or even ongoing challenges such as systemic oppression or harm passed down through generations. Understanding trauma this way helps us appreciate how complex it is and why trauma-informed care needs to be compassionate, flexible, and tailored to each individual's experience. Trauma doesn't just affect emotions, it changes the brain and the body. The amygdala, or threat detector, as most of you guys know, becomes overactive so that the alarm system goes off even in safe situations. The hippocampus struggles to store memories properly, leaving gaps or fragmented flashbacks. And the prefrontal cortex, which handles logic and regulation, often goes offline, making it hard to just calm down. And through polyvagal theory, we see how trauma impacts the vagus nerve, driving fight, flight, freeze, or shutdown responses. In short, trauma rewires the survival system, which explains why it's felt in both the mind and the body. One of the most important things to understand about trauma is that it doesn't look the same for everyone. It could come from a single shocking event, it can build up over years, or it can even be carried across communities and generations, as I explained in the previous slide. For example, a car accident might trigger an acute trauma response, sudden, overwhelming, and life-changing in one moment. In contrast, chronic trauma is more about the drip-drip effect, like living in a home where there's constant conflict or violence. It's not one moment, it's the repeated exposure that wears down a person's sense of safety. With complex trauma, the impact often starts early in life and involves relationships. For instance, a child growing up with abuse or neglect. Because it happens during development, it doesn't just affect how someone remembers the past, it also shapes how they see themselves, trust others, and regulate emotions in the present. And then there's historical or collective trauma. This is bigger than the individual. It's a trauma of colonization, systemic racism, war, experiences that ripple out into entire families and communities, sometimes for generations. So when we think about trauma, we're not just asking what happened to you, we're also asking how did it happen, how often, and in what context, because each type requires a slightly different lens for healing and a slightly different approach that we will talk about in later slides. When we look at the consequences of trauma psychologically, trauma can lead to PTSD, depression, anxiety, shame, or even disruptions in one's identity. A lot of people may feel like they lost a sense of who they are. Somatically, trauma lives in the body. A lot of people who experience a traumatic event or have trauma in their lives often report chronic pain, digestive problems, or even autoimmune conditions. A lot of people and a lot of clients often get into their head about these somatic symptoms. However, these are real physical consequences of a dysregulated nervous system. Relationally, trauma can interfere with trust and intimacy. Someone who's been hurt in close relationships, for example, may struggle with that attachment piece, always waiting for that betrayal or abandonment. Behaviorally, trauma can drive coping patterns like substance use, dissociation, or hypervigilance. These are not signs of weakness, but survival strategies that made sense for them at the time, even if they became harmful later. So when we talk about trauma, we're not just talking about symptoms. We're also talking about a whole personal impact. So psychological, physical, relational, and behavioral, which is why trauma-informed care needs to address not only these aspects individually, but also address the layers together. So as we move on to this slide, I really want you to take a look at the Canadian context of trauma and the prevalence and impact of trauma in Canada. So when we look at this context, trauma isn't rare. It's actually quite widespread. For example, Statistics Canada reports that about 65% of Canadians will experience at least one traumatic event in their lifetime. That's nearly 2 out of every 3 people. Of those, around 8% experience moderate to severe PTSD symptoms in any given month. The lifetime prevalence of PTSD sits around 9%, but at any time, about 2% of Canadians are actively struggling with it. Some groups are more vulnerable. Women and young adults 18 to 24, for example, report significantly higher rates. Risk is also compounded by factors like low income, poor health, limited social support, or substance use, things that make recovery a lot harder, as we all know as practicum students. Severe events like sexual assault or captivity are most strongly linked to PTSD, and beyond individual suffering, the impact reaches workplaces and communities. For example, nearly 38% of people with PTSD report reduced capacity at work, compared to only 5% of those without PTSD. So the main takeaway here is very clear. Trauma isn't an exception in Canada. It's actually fairly common, and its impact is felt not only in mental health, but in physical health, relationships, and even in the economy and the workforce. So when we take a step back and really look at why trauma care is so important and so fundamental, especially in the Canadian context, especially when you look at with every 2 in 3 Canadians experiencing trauma, it's important to understand that deep impact of trauma. And as I discussed in the previous slide, how trauma alters the brain and body, fueling PTSD, anxiety, depression, and many more psychological disorders. We also looked at the hidden cost as well, and that public health crisis where childhood trauma raises the risk of addiction, disease, and early death. So healing is really fundamental and key here because trauma care restores safety, identity, and resilience. So before we jump into the models and interventions, I just want to pause here and talk about why the foundational lens we use matters just as much, if not more, than the actual tools that we bring into the therapy room with our clients. The first point here highlights a critical risk. Trauma treatment without a trauma-informed lens can actually do more harm than good. So according to Herman, when we skip over safety and jump right into the content and exposure way too soon, we actually risk re-traumatizing the person sitting in front of us, even with the best intentions. The second point reminds us that any therapeutic approach is only effective if it's delivered safely. What does this mean? This means attending to the power dynamics, pacing, consent, and emotional regulation before we start doing the heavy work. And finally, point 3 reframes what trauma-informed care really is. Trauma-informed care isn't just a set of strategies, it's also a stance. It's about how we deliver therapy, not just what model we're using. That includes our tone, posture, flexibility, attunement, and our ability to co-create safety in the room. So if we take anything from this slide, it's that a trauma-informed foundation isn't a bonus feature, it's actually the ground everything else stands on going forward in our work. On the screen, you will see 6 core principles of trauma-informed care as outlined by SAMHSA in 2014. On the screen, you'll see that none of these are actually treatment techniques. They're relational and environmental pillars that guide how we show up for our clients regardless of what modality we're using. So it's really the groundwork. The first is safety, both emotional and physical. A trauma-informed space should feel predictable and non-threatening for our clients that are going through traumatic events or working through traumatic events. If a client's body doesn't feel safe, no intervention going forward will land. Trustworthiness. This is all about transparency. Clients need to know what's going to happen in session, what the boundaries are, and that their therapist won't surprise them. Collaboration means moving away from a power over dynamic. It's not about fixing the client, it's about building a therapeutic relationship and partnership where decisions are made together. Empowerment is essential. Many trauma survivors and trauma clients have had their autonomy taken from them, so we always want to support choice, voice, and control in the therapy process. Cultural humility means to recognize that trauma doesn't occur in a vacuum. Historical, systemic, and identity-based traumas are real, and a trauma-informed stance must also account for these. And finally, trauma-informed care is a framework, not a treatment model. You can be trauma-informed whether you're practicing CBT, IFS, EMDR, or anything else. It's about how you deliver your care, not what method you use. This slide highlights one of the most critical responses we carry as trauma-informed clinicians, protecting our clients from being pushed too far, too fast. Let's start with what flooding or re-traumatization might look like within our clients and signs that we could look for as trauma-informed clinicians. The signs are often very subtle but powerful. Signs include, and are not limited to, dissociation, shutdown, or overwhelm. These aren't necessarily signs of resistance or avoidance from our clients, but they're signals from their nervous system that is perhaps maxed out or flooded. Re-traumatization often happens when we move into the trauma content before the client is actually ready. So whether that's due to therapist pressure, system demands, or even our own unconscious urgency. It can also happen when we skip over that emotional regulation and stabilization pieces or assume that a client's verbal consent equals their full body readiness. To prevent this, we use the concept of the window of tolerance, which many of you who are in your practicum might be familiar with. The idea is quite simple here. There's a range of arousal where clients can engage, process, and reflect without becoming dysregulated. So it's very important that we introduce the window of tolerance to our clients in a psychoeducation dynamic where they are informed of the approach and where they are in terms of their window. As Bands and colleagues reminded us in 2022, trauma must be processed in tolerable doses, meaning it's not just what we process, but how much and when we process these things with our clients. The practice of pendulation is very key here. This means properly moving between safety and stress, between grounding and activation. We don't sit in the trauma content continuously. We kind of dip in and out. So our job is to stabilize first and then work with our client second and let the client set the pace when processing through their traumatic events. When in doubt, we go slower. That includes building in resourcing, grounding, and regulation breaks as standard but not optional parts of our work. All right, let's take a little break here. Now that we've explored the risks of re-traumatization, the role of pendulation, and the importance of staying within the client's window of tolerance, I want to bring this into practice. So this activity invites you to think like you are a trauma-informed clinician. Imagine you're working with a client who has just disclosed trauma. Your task is to design a simple 3-step pacing protocol that reflects everything we've just covered. So you'll include one strategy to prevent flooding, something proactive you do at the start of the session, one technique to detect when a client is getting close to their edge. This could be a verbal, physical, or energetic cue, and one method you would use to bring them back into the window of tolerance in their regulation. Maybe a grounding practice, a shift in focus, or maybe co-regulation. Keep your answers simple and clear. This is about building real-world readiness to pace gently and to prevent harm for our clients. So this can be done as a written activity, and I'd love for you guys to share in the discussion posts this coming week on your 3-part pacing protocol, and interact with your peers and engage with your peers and compare and contrast as well. This slide outlines Judith Herman's foundational phase model of trauma recovery published in 1992. Even though this model was published in 1992, the model remains one of the most widely used trauma recovery frameworks today and emphasizes that trauma healing is a non-linear, staged process and that safety must always come first with our clients. In the first phase that you'll see on your far left, the primary goal is to help the client feel safe. So this is all about safety and stabilization, both internally and externally. This includes developing emotional regulation tools, container exercises, reducing symptoms like flashbacks or dissociation, and building a strong, trusting, therapeutic alliance. Until the client has enough tools to stay grounded, we do not move into the trauma processing. In phase 2, once stability is in place, the second phase focuses on gently working through traumatic memories. This can include narrative work, somatic reprocessing, or even EMDR. All of these and which I will go through in later slides, but always with the consent of the client and the right competency from us as therapists. The goal here is to help the client give voice to their story, integrate what happened, and release the stored emotional energy. Moving on to the last phase, integration and reconnection. This phase is all about helping the client reclaim their life. This includes strengthening their identity beyond the trauma, restoring these relationships and reconnecting with their community, or even reconnecting with their own purpose, and also redefining their safety and their sense of safety on their own terms. We support them in moving forward, not as someone broken, but as someone who is rebuilding. In this slide, you'll see a quick snapshot of several well-established evidence-based models commonly used in trauma therapy. And like I said in the previous slide, there's no one-size-fits-all approach to trauma clients and addressing our trauma clients, and this is actually seen as a good thing. Each one of these approaches and modalities brings something unique to the table, targeting different systems, symptoms, or entry points into healing. I'm not going to break them down all here just yet, but I want to introduce them now so you kind of have a mental map for what's coming in our later slides. You'll notice the list includes cognitive models like TF-CBT, neurobiological models like EMDR, body-based approaches like somatic therapy, parts-based and relational models like IFS and EFT, and meaning-making approaches like narrative therapy. We'll explore these models in more depth later on. For now, just hold on to the idea that there are many valid pathways to healing, and our job as clinicians is to know when and how to use each one through a trauma-informed lens. Let's pause here and ask a key question. What actually makes something trauma care? And what actually makes it a trauma care approach? Not just therapy that happens to involve trauma. This slide outlines 5 core elements that distinguish trauma care from traditional symptom-focused treatments. We start with safety. Without emotional and physical safety, both in the therapy room and in the client's life, there is no ethical ground for trauma work. Stabilization comes before processing, as explained in the earlier slides. Trauma care is never about pushing through. It's about working in small, digestible pieces. We're not trying to get to the full story in one session. We're trying to work within the client's capacity to stay present. Trauma doesn't just live in the mind, it lives in the body, as I said at the beginning quote. A trauma-informed approach must recognize physiology, how trauma alters the nervous system, posture, pain, and even digestion. This means incorporating body awareness into our work. We're not the expert on the client, they are. Trauma care centers the client's voice, autonomy, and cultural lens. They set the pace, they guide what's shared and when. Our role is to support, but not override, that control. Lastly, trauma care goes beyond symptom relief. We're not just trying to stop those nightmares or reduce those panic attacks, for example. The deeper goal is to helping clients restore this resilience, rebuild identity, and reconnect with meaning and relationships, things trauma often strips away from our clients. Let's start with trauma-focused cognitive behavioral therapy, or TF-CBT. This is one of the most well-established evidence-based models for children and adolescents exposed to trauma, especially interpersonal trauma like abuse. It's grounded in the cognitive behavioral framework, which looks at the connection between thoughts, feelings, and behaviors, as we probably all know. As shown in the diagram here, CBT operates on the idea that these three areas constantly influence each other. A thought can lead to a feeling can drive a behavior, and a behavior can reinforce a belief. TF-CBT builds on this foundation, but with specific trauma-focused components. TF-CBT is structured around the PRACTICE acronym, which includes psychoeducation about trauma and its effects, relaxation skills to manage the physical symptoms, affective modulation to help regulate these emotions, cognitive coping to shift unhelpful trauma-related thoughts, trauma narrative and processing, in vivo exposure to reduce avoidance of these trauma reminders, and conjoint child-parent sessions to enhance connection and safety, and finally, enhancing safety to support long-term healing. TF-CBT has a strong empirical base, especially for survivors of sexual abuse and childhood trauma. It's typically short-term and highly structured, what makes it accessible and scalable in many settings. One limitation that I would like to note, though, is that it can actually be too cognitively demanding for clients who are highly dissociative or disconnected from their body. These clients may need additional somatic or stabilization work before they jump into the TF-CBT. Overall, TF-CBT is a great entry point for trauma work when the client has some stability and cognitive capacity, and when relational repair, especially with caregivers, is a part of the healing goal. Now let's talk about EMDR, eye movement desensitization and reprocessing. This model was developed in 1989 by Francine and has become one of the most widely recognized and empirically supported treatments for PTSD. The core mechanism of EMDR involves bilateral stimulation, such as eye movements, tapping, or tones, while the client recalls traumatic memories. The goal here isn't to re-experience the trauma, but to allow the brain to reprocess the memory in a way that feels less distressing and more adaptive for the client. It's believed EMDR supports something called memory reconsolidation, meaning the emotional change of the memory is reduced while the factual content remains intact. Importantly, both the APA Association and the World Health Organization recommended EMDR as a frontline treatment for PTSD. EMDR is especially helpful for clients who struggle to talk through clients. It can offer a more experiential, less verbally demanding pathway to healing. However, there are also critiques to this one. EMDR isn't always the right fit for clients with high dissociation or poor affect tolerance, because the processing can be very intense. And while the outcomes are strong, there's still some debate about the why. We know it works, but the exact mechanism isn't fully agreed upon. In short, EMDR is a powerful tool when used appropriately, especially with clients who are resource regulated and ready for targeted trauma reprocessing. A lot of this work is also done on veterans and first responders. Somatic approaches to trauma therapy recognize that trauma isn't just stored in our thoughts or memories, it's also held in our body. One somatic modality is somatic experiencing, which was explored by Invito and Masali in 2024. This approach focuses on bodily sensations as a way to track, contain, and ultimately discharge trauma responses. It uses techniques like titration, meaning that trauma is processed in small, manageable doses, and pendulation, which involves guiding the client between states of distress and safety. This helps prevent overwhelm and builds tolerance. Another body-based modality is sensor-motor psychotherapy. This integrates body awareness directly into the trauma narrative, and it helps clients notice how their body reacts as they recall difficult memories, allowing for a more regulated, embodied processing. The overreaching goal of somatic work is to complete the body's interrupted survival responses, like fight, flight, or freeze, so the nervous system can return to a regulated state. These approaches are particularly effective for clients with complex trauma or dissociation, where talk therapy alone may not be enough. Now we're going to take a look at the internal family systems model. This was developed by Richard in 1995, and this model offers a really compassionate lens on trauma healing for our clients. IFS is built on the idea that the psyche is made up of distinct parts. These parts often fall into categories like protectors, exiles, and firefighters. Each part has a role, and trauma happens when certain parts, like the exiles, get burdened with painful experiences and are pushed out of our awareness. One of the most powerful aspects of IFS is the concept of self-energy. Healing begins when the self, our core, undamaged essence, can lead with curiosity and compassion. This allows the parts to unburden and reintegrate. Research actually shows that IFS can be especially effective for complex trauma, shame, and dissociation. What makes IFS unique is how it frames symptoms instead of seeing behaviors as pathological. It empowers clients by viewing them as protective. More specifically, protective strategies that make sense at the time. This reframing can reduce shame and increase client agency. Emotion-focused therapy, or EFT, is a trauma-informed approach that's deeply rooted in attachment theory. EFT recognizes that trauma often disrupts attachment bonds, making it difficult for clients to feel safe or securely connected in relationships. This model is centered on providing corrective emotional experiences, which includes building attunement, encouraging emotional awareness and expression, and helping clients restructure maladaptive emotional responses. EFT has strong evidence behind it, particularly in couples therapy for trauma survivors, and it plays a key role in repairing the relational wounds while also fostering that emotional safety piece. But like every model, EFT isn't without limitations. It often requires clients to access and express emotions directly, which may feel overwhelming or inaccessible for individuals who are deeply avoidant, highly dysregulated, or early in their trauma recovery journey. It may not be the best entry point for those needing stabilization first, or for those with high levels of dissociation. Lastly, we have narrative therapy, which was developed in 1990. This approach is based on the idea that trauma can shrink identity, causing people to view themselves through the narrow lens of what happened to them. Trauma survivors and clients may start to believe, "I am my trauma," instead of seeing themselves as whole and multidimensional. Narrative therapy invites clients to reauthorize their stories, meaning they get to reclaim authorship over how they see themselves and their lives moving forward. According to Nicole, this involves externalizing the problem, thickening that alternative narrative, and witnessing stories in their community, which can be incredibly validating, especially in group therapy or cultural spaces. This modality is especially empowering in collectivist and indigenous contexts, where healing often involves relational, cultural, and spiritual dimensions, not just individual introspection. So let's bring everything we've learned into light with this case. Here we have a 25-year-old woman presenting with a history of relational trauma, things like emotional neglect and inconsistent caregiving. She's now showing signs of dissociation, shame, intimacy difficulties, and deep fear of abandonment. These are common symptoms for survivors of relational trauma, especially when love and safety were unpredictable in childhood. So here's the question I want to pose to all of you, and I encourage you guys to write in the discussions next week. What would you do with this client? What models would you lean towards? Would you prioritize stabilization first? Would you go somatic, narrative, or attachment-based? What would you be mindful of when working with someone who's never felt safe in closeness, but is craving it? So on this slide, I want to show you an example of how you might apply different modalities into the treatment plan as a phased approach. So again, phase 1, stabilization and safety. We already discussed this. This is really about the grounding and the mindfulness, as well as that psychoeducation and the nervous system work and building that trust and that alliance with your client. Phase 2, an example of something that would be really great for trauma processing. IFS, working with those shame-based parts, somatic grounding, body scans, pendulation, breath regulation, as well as maybe some gentle exposure at the client's pace. Phase 3, narrative reauthoring. This is a part of that integration and growth, shifting that identity beyond the trauma, strengthening the resilience and the values-based living, and also rebuilding the capacity for safe, trusting relationships. Again, this is just an example of how you can use those modalities together in different layers of the therapy plan using that phase-based approach. Now let's look at how we can apply trauma care approaches in counseling in different settings. So when we look at this Venn diagram that I created, in terms of individual counseling, in the one-on-one sessions, we prioritize stabilization and grounding. Therapists often integrate different modalities like IFS, CBT, somatic interventions, while centering the client's sense of choice and control, which is a critical component in trauma recovery. Moving on into group counseling. In group counseling settings, this offers a unique perspective and also unique benefits such as peer validation, where clients realize they're not alone in their reactions and in their stories. Something that can be very incredibly healing. Groups also reduce isolation by fostering safe connection and community. Structured faculation ensures that trauma is processed in a regulated and supported way. In terms of family counseling and even couples counseling, that often focuses on repairing ruptures, supporting caregivers or couples in understanding trauma responses and building relational safety. This is especially relevant when trauma occurred in attachment relationships. Helping rebuild trust can be a key part of healing. Regardless of the setting, safety and empowerment must remain at the core. Whether working with an individual client or an entire family system, the goal is to restore agency, build connection, and regulate the nervous system. Trauma-informed care and trauma care approaches can actually go much more beyond the therapy room. It's a framework that can radically shift how entire systems operate. For example, in schools, this might look like creating physically and emotionally safe classrooms, training and educating teachers in trauma-sensitive approaches, especially in communities that are already vulnerable and susceptible to trauma to begin with. In workplaces, trauma-informed practices involve policies that actively prevent re-traumatization, like staff wellness initiatives, peer support programs, and leadership trainings that prioritize psychological safety. This is especially important in the first responder workplaces as well. In justice and community systems, so this might look like restorative justice practices, focusing on equality, community healing, and inclusive processing that center survivor needs and trauma needs instead of perpetrating harm. At the core of all of these is a commitment to empowerment, choice, and creating environments where nervous systems can feel safe and that go much beyond the therapy room. As counselors, our work with trauma affects us too. Sitting with stories of pain puts us at risk for vicarious trauma, compassion fatigue, and burnout. This is why it's emphasized that self-care is critical, especially when we face personal stress, because our ability to support and tend to clients depends on how well we care and tend to ourselves. Secondary traumatic stress can mirror PTSD symptoms, which is why self-care is not optional but an ethical responsibility in our profession. Practical strategies include supervision and peer consultation to reduce isolation, mindfulness and grounding to regulate our nervous system, and maintaining clear boundaries and work-life balance to sustain resilience. The key takeaway: self-care is foundational to safe, ethical, and effective trauma-informed counseling. When we sit with trauma, we're not just holding a story, we're holding a person's nervous system, dignity, and deepest wounds. Therefore, ethics aren't just guidelines here, they're also lifelines. Trauma clients are highly vulnerable, often carrying histories of broken trust and re-traumatization from previous systems. The CCPA reminds us that our work must center dignity, safety, and informed choice at every step. Some key principles include, but are not limited to, do not harm, go slow, pushing too fast can re-traumatize, informed consent, make sure to explain risks, benefits, and confidentiality in a clear and concise language, Competence, stay within your scope, seek supervision, and pursue trauma training. Boundaries, maintain professional distance. Boundaries are protective and also healing. And self-reflection, monitor your own reactions to prevent harm to yourself. The key takeaway here is that ethical trauma care means safety, transparency, competence, and accountability. Commitments we live out in every session. Trauma doesn't look the same for every client, so the way that we show up in our counseling can't either. Culturally responsive practices means meeting clients where they are with humility, openness, and respect for the systems that shape their lives. It starts with cultural humility, listening deeply, staying curious, and honoring clients' values instead of assuming expertise. For example, for many Indigenous clients, healing is rooted in culture, ceremonies, storytelling, or involving elders. These aren't extras, they're central to their recovery, so we as therapists have to honor that. We also recognize that healing is relational. Communities, families, and cultural groups are often key supports in the process, and we must apply an equity lens, naming and addressing barriers like discrimination or lack of access to appropriate services. The key takeaway here is effective trauma care is not just about theory. It's about weaving together neuroscience, cultural knowledge, lived experience, and community wisdom. As we come to the end of this presentation, let's just take a quick step back and reflect on what we've covered. First, we explored how trauma reshapes the brain, the body, and our sense of identity. We then looked at how trauma care must be phased and paced. We can't rush people into processing, and we need to start with that stabilization piece. We also acknowledged that no one approach is enough. The most effective care is integrative and flexible, tailored to the person and the client in front of us, not a one-size-fits-all protocol. Ethical trauma care means building everything on safety, trust, empowerment, and cultural humility. These aren't optional add-ons, they're the fundamental groundwork for the therapy that we provide. And for us as practitioners and counselors, we have to prioritize reflective practice and self-care to sustain ethical, grounded work in the long term. So the core message that I hope you walk away with is trauma-informed care and trauma-informed counseling means creating space for safety, choice, cultural responsiveness, and true integration. When we hold these values into our work, we help clients move not just towards surviving, but towards meaning, connection, as well as healing. Thank you very much, everyone, for listening to my presentation on trauma-informed care. I invite you all to bring your voice into this conversation, so I just want to end off with a discussion and a reflection. Next week, we'll be continuing this dialogue on the discussion board, so I encourage you to choose one of these prompts and post a reflection, share some examples, and maybe share how you incorporated the case studies and what you did with the case studies, or even challenge some of the ideas presented here today. Trauma-informed care isn't just a checklist, it's a big commitment. So these conversations are a big part of that commitment as well, and I look forward to hearing your responses.